You and I are both radiation oncologists, and as you mentioned earlier, in order to deliver these therapies, you need an authorized user. Can be a radiation oncologist, can be a radiologist, most commonly a nuclear medicine physician. But you and I are both radiation oncologists, which in the community setting, I have found has been relatively more common, I would say, and I think that probably anchors in just to how radiation oncologists fit into the community over the last few decades, incorporation in multi-specialty groups and hospitals. But let's talk a little bit about radiation oncologist role in your opinion and in managing these therapies, how you see this role has developed over the past few years and will continue to develop. So radiation oncologist managing a systemic medicine. How do you see that platform, that advent that we are now players in the systemic therapy space? Tell me about your perspectives of in your in your health system in US oncology, how you've seen radiation oncologists had to shift a little bit and think in terms of systemic therapy, and what sort of growing pains or adjustments that you and your fellow physicians have had to make in these therapies, if any.
Yeah, no, I think that's a great call out, right? Because as you look at the development of radiation oncology in general, most of what we do are going to be targeted therapies or directed therapies that address only one part of the body. But we've always really done that in a larger context, right? So many of the treatments that we give, we're going to give chemotherapy and radiation at the same time. And so even though we might not be delivering that systemic treatment, we are oftentimes thinking systemically, because where we treat and how we treat with external beam radiotherapy often encompasses not just like the gross disease, the disease that we can see, but we're often developing external radiation fields in ways that encompass microscopic disease as well. And I think as I think about this is to me kind of an extension of that larger paradigm. Where it's a little unique is most of these therapies thus far are indicated in patients with widespread metastatic disease. And so for me, when a patient comes to me with widespread metastatic disease, I'm often just helping with one part or another part because it's causing pain or threatening function. Whereas this is a therapy that, as you said, it's systemic. It goes throughout the entire body, treats the cancer no matter where it's at. And I do think that in this setting, there are some things that you need to think about a little bit differently, and that our radiation oncologists in the community are thinking about differently. One of those things is side effects, right? As we think about a systemic therapy versus a very targeted course of external beam radiotherapy, now you have to think a little bit differently about side effects, fatigue, and bone marrow suppression, those types of things. But you also have to think about effects that are going to happen outside of your intended target, right? So for Pluvicto specifically, thinking about things like dry mouth that may persist after your treatment and may have implications further down, as you go to ongoing therapies. I think additionally, as some of these therapies pull forward in where you deliver them, right? So for Pluvicto, as it's gone from post chemotherapy, post androgen receptor inhibitor to now pre-chemotherapy and perhaps even earlier, I think you do have to be a lot more cognizant of things like long-term kidney function or other things that you might affect. I think the other thing is how the referrals start to come in, right? Many times in an academic practice, often these referrals may go straight over to nuclear medicine. And in many of our private practices, there may not be that nuclear medicine doc that's going to take over or deliver Pluvicto or Lutathera. And so these are coming to radiation oncologists. And I think that's a good thing, in the sense that we have a lot of experience looking at kind of a whole patient and saying, what's not just the thing that we're looking at right now, but where is the overall picture of this patient's cancer, and how does this particular therapy fit in versus what are some other options? Because there often are other options for these patients.
Yeah, you bring up some great points. And as a fellow doc in the community, I've noticed that I've had to work with my medical oncologists and urologists in a different way than before. We get concurrent chemoradiation often, and there's often that collaboration. But often I just feel like in those settings, those patients, it's like I've got my corner, which is the external beam, and
Sure.
you've got your corner, which is the systemic therapy. But here we're
Hmm.
both working on the same side of the equation,
Yep.
looking at labs together, making sure that all these side
Hmm.
effects are being appropriately managed, that they're not being missed. I've also found in my practice that every referring doc is a little different. Right. Some want to be really involved in the management and will want to see the patient routinely in between cycles. Others will just say,
Sure.
"Hey, Dustin, just take care of it." Have you noticed that as well?
Yeah, I think it varies by practice. In my own practice here in Minnesota, I'd say most of the docs are going to say, "Yeah, you go ahead, you deliver it. I'll see them maybe halfway through, and then I'll see them when they're done." And then I've got other practices, in other parts of the country where either the medical oncologist or sometimes the urologist do just like you're saying. They stay very, very involved and they're up on top of the labs. And yeah, I think it's a rapidly evolving field that will likely change. 10 years from now, the way we do it now is probably going to be very, very different.
Yeah, no, I agree with you.